little bit first about change. And actually, turns out in my long, colorful, and circuitous career, I actually worked a bit on behavior change when I was on the faculty at UCLA, and it turns out that even in apart from the people who have special challenges with opiate use disorder, awfully tricky and hard. If you have to say nothing else, well, we know change is hard. Then to talk a little bit about the stages of change and approaching it, particularly with respect to opiate use disorder. And then, since Andrew said that there might be some interest, we can talk about particularly about buprenorphine. But what I would want to invite everybody to do is please at any point weigh in, including this is not, this isn't a speech. So people say, no, just please stop talking and can you get us talking about this other thing. So at some point soon I'll do that. Let me just, I'll go through the next little bit, and after that it'll be, I hope, a free for all. So let me start with a little bit of a brief detour, which is tobacco. So let's say, yeah, just sometimes, and again, not this crew, but I think it's really important to remind ourselves, or to remind the public that, look, it's not, partly because of the stigma, and because of the dangerousness of a lot of of just what folks are going through. We tend to focus massively, or there's a huge kind of emotional investment in OD, but there's a whole lot of behavior change out there, which is, if anything, probably even harder, and that we tend to overlook. And so tobacco, it can be instructive just to look for a minute at those things and say, well, okay, in the world of tobacco cessation, 67% or so of adults say they want to quit. 50% of those people in a year may try, and that, if you look here, I said success, 8.8% of adults who are smoking who tried to quit in a year quit. To say, oh, only 9% quit in a year, really, really hard. And those are people who want to quit, okay? And it often, the other data said it takes 5 to 6, or depending upon whose study you look at, up to 10 serious attempts to quit smoking. Okay, and so really, really hard. It's something that we don't ordinarily think of, saying, well, it's hard as folks on opiates, but really, really hard. It's behavior change is hard. Humans are massively creatures of habit. This is probably for good evolutionary reasons. It allows us to do all kinds of things with nearly not thinking about it, but it means that all kinds of things get to be habits. And hope I can do this fast, but just to say that the personal story here is, just for amusement purposes here, I'm actually the son of a psychiatrist and a psychologist. And when my parents were in early 40s or so, we got the message that tobacco was seriously dangerous. Okay, so my father smokes a pipe and cigar, and my mother smoked cigarettes, as a lot of professional people did it at that stage. And they both started to try to stop each of those habits. My father used to say, well, he was ahead, but he would steal my mother's cigarettes and smoke them in his pipe. and then my mother eventually stopped and got onto nicotine gum, which he proceeded to chew for 40 years. My father eventually quit entirely, but just so in case you think that he was somehow more virtuous or more disciplined, even as a psychiatrist, continued to, with a terrible habit which he had, which was chewing his fingernails down to the nub, which he did until he died in his 90s. So just as a reminder, even for, if assuming that we said, oh, people have all the resources and all of the insight and all of the education, really, really hard. Okay, it's hard. So that's where I want to start us. Okay, and this stuff is probably really familiar to everybody here, and stages of change. We all know about this, the trans-theoretical model. Why I like this and putting this up, and as I say, to look at the reference links, because there's some great material in here. I never seen it laid out visually quite this way. So I sort of think of it as, oh, well, here on the left-hand side is the march through pre-contemplation, contemplation, preparation, action, maintenance. You just march through. Said, oh, this one from BU, which is one of the major centers for working on addiction. I'm sure many of you know. I said, it doesn't work like that, right? You don't just sort of go down the ladder and then you're done. This is trying to think of the thing, pointing out that a straight linear model does not work. We know that all of these things, again, all kinds of habits are chronic, lapsing, relapsing. You sort of get ready, you get to a point, you enter. It looks a whole lot more like that. So that's the other thing I think, visually just to remember. Oh, it wasn't, we're not just putting people on a straight march through the thing and then happily they will, get to the end and we're done. It doesn't work like that. And whether it exactly works like this picture from this BU resource, say, yeah, but it's a whole lot more circular or complicated spatially, however we're going to think about it. Okay. And then here's some, I think very good points. The stuff that this model does not include is some of the most important things that I think that we probably have to talk about concretely. It includes things like, well, social circumstances, right? All of the things which are now on our radar about the ways in which people's experience and stress affects how we deal with this. Okay, so I think also really important. Okay, so now let me stop here. I'm putting this up, but I don't want to go through that unless people want to hear specifically. But I'd like to hear now from the group about what's on everybody's mind or experiences with this or special challenges that we've had either in the community work or in the health offices with helping people, particularly with opiate use disorder. The stuff that follows is either two things: either stuff that I have gleaned or my adaptation of some of this through my 10 years or so working pretty hard on this, and then some if people are interested in this in the material that's specifically to do with buprenorphine. I can talk a bit more about that. So I want to try to shut up for a little bit here now and hear what folks are most interested in. Andrew said the group wasn't shy, so you guys better not disappoint me. No, any of the folks from the health offices who are completely new? Oh, there's a hand up. Ashley, please.
Hi, I wanted to know if you could talk a little bit about different buprenorphine inductions, especially like the Burmese method or like micro induction versus macro induction.
Sure. So, about approximately what you're talking about, Ashley? About that?
Yep.
Okay. So, so for everybody, so please just jump in, Ray. If it's on the topic of inductions, please just jump right in.
Yeah, I just wanted to ask particularly about talking to people pre-MAT when they're just thinking about it, because a lot of our harm reduction clients have some knowledge. It's not always correct, it's not always complete, but just how to engage someone to start the conversation, to think about it, and perhaps do something about it.
Sure. Okay. Good. So since Ashley jumped in first, let's do a little bit about the induction and then come back to that. That's a very good point, and I have some notes about that, and then we can also trade thoughts about that. Obviously, we've got some people like Phil and Maria there as well. So I would be very glad to hear about what they would have to say too. Okay, so first of all, buprenorphine induction. So probably most important, and I know we've got sort of a mix of people's with expertise, so I'll say a little bit about it. Stop me if it's too basic or stuff that you already know. But buprenorphine is a great medication. I mean, for the job, you almost couldn't design a better medication. Even just said, look, here's my wish list of what the thing would do. it's pretty fantastic. However, given that we're talking about what it addresses is the opiate receptors in the brain, and when they're filled and when they're not, the mu opiate receptors, um, this is where it gets tricky, because what we know about buprenorphine is that it's what's called technically a partial agonist, partial antagonist, that it works partly positively and partly negatively, negatively being like Narcan on the receptors in the brain. So the trick with it is it's such a great medication because once you get enough of it on board for everybody who is in any physical sense dependent on opiates, it will make them feel better. They won't have withdrawal symptoms, they won't feel sick, they won't have cravings, physical cravings. But that initiation, or I don't know why this word that got established in the world of buprenorphine and Suboxone early on, calling it induction, it just seems sort of crazy. I don't know, it doesn't makes it seem like some special ritual, but not. I don't want. Anyway, I prefer initiation anyway. Um, um, that it's those first doses which are tricky, because if people have the fentanyl or whatever opiate on board, it will act like Narcan. Okay, so all of these different strategies, which Ashley was mentioning, are meant to contend with that. Okay, so if we look at these, the standard, which I'm not sure that this doesn't seem entirely right. I mean, starting with very sort of creeping doses originally, but the standard was, it used to be, so in order not to throw people into withdrawal, in order for the buprenorphine not to act as it will initially, like naloxone, you say, well, okay, we've got to do something about letting them to get into withdrawal. Okay. So originally saying, okay, well, we'll tell them to wait kind of a long period, which in that standard, which again, this is, I don't know whose standard that was. That's awfully long time for people to wait, up to 48 or 72 hours, but before they start, and in small doses. Okay. So the idea is that you don't want to make them too sick, and so we sort of creep up in it. Okay. Then the variation on that, which I think is actually probably more standard, certainly recently, and particularly in the world of fentanyl, is what's called here the quote high dose induction, which is to say, okay, have people wait until they're feeling sick enough and then give them a lot. Okay. Now, I will tell you, just in as a matter of full disclosure, I am a strong proponent still of this, essentially the high dose method, and even particularly for fentanyl. And say, why is that? Because some of the other methods, including some which are doing things like giving people naloxone or Narcan, I find actually put people more through the ringer, and they also tend to undermine what I feel like is the most important part of the message of the pharmacology of buprenorphine, is that people will feel better. And the answer is, if you don't, even if it's too early, say if you wait here, say, well, the amount of time you're supposed to wait before starting it, even if you do this, if you just give them a whole lot, and says a whole lot, said 16 to 32 milligrams, even up to 40 milligrams, there is almost nobody who will not feel better after 32 or 40 milligrams. Doesn't matter what happened, doesn't matter if I threw them into immediate withdrawal, they will. And now, you don't want them to, the biggest problem is that some of these people may run away, say, well, they're going to leave your detox, or they're not going to keep at it, and they'll go use. They say, well, no, but if they take enough, they will be fine. So if you're just aware of that, they will do fine. If they're not feeling well at that point, it's probably other things. Remember that many people are using other things, and that tends to cloud things. Okay. So now, is any questions about that before I get around finally to Ashley's actual question, which was about the low dose approach or microdose approach? Any questions? No? Okay. Boy, you guys are.
Oh, I have one,
Yeah.
Dr. Leiderman. I'm
Of
sorry.
course, please.
This is Monica.
Please go ahead.
So how do you determine, like, depending on how much fentanyl they're taking, or do you do blood work to see how much is in their system to determine what dose you give them? Because I'm having some of my participants telling me that they're taking like, 20 or 30 pills of fent a day. And I'm like, and when I even mention Suboxone, they're kind of like, well, no, it's just going to make me sick because they can't give me enough. What do I
Right.
tell those people?
I'll say no, probably because, so the most important thing to tell people in that situation is say, well, if they had experienced it on the street, usually they didn't have enough. It'd be rare for anybody. I've never heard of somebody buying 5 strips and doing it all at once on the street. I mean, they just don't do the same. They buy it a little bit. So I said, yeah, well, that's why it made you feel sick. Because that first, if you're using Monica, people even more than that, 40, 100, I've heard people using more than 100 pills of fentanyl a day, said, 1 strip isn't nearly going to cover you. And that first one that you took just made you feel sicker because probably you didn't wait long enough either. So no, you haven't had an adequate test. Now, one of the things that has happened in since we live in a fentanyl world now is that the official sort of indicated, so the official medical establishment doses have been raised. So 32 milligrams is officially, endorsed now, and there's no reason that you couldn't even get more. Now, it's hard to say. It would take very technical studies of labeled medications and brain scans and all kinds of things to establish whether or not people have their receptors filled. But I have not ever encountered someone who was a regular street user who wasn't going to be pretty okay on even just 24 and maybe 32 a day. But the fact is, because most folks don't do a proper test or they don't start it the right way, they get this fear of the Suboxone, which is why I like the idea of saying, making it very clear to them on how to start it. Say, look, you got to be pretty sick first. It doesn't matter if they be completely sick, but say you got to wait at least 16 hours. And I prefer to tell people 24 hours. Now, what's good about fentanyl? Almost nothing, but it actually is a very rapid medication. So it's actually off board quickly. The problem is that people are using it so frequently that and that's part of this, obsessive use with the fentanyl because it comes off so quick, right? So that's why people have to go back for it. So they're not used to waiting long. So giving them stuff to help them feel better while they're doing that. But you have to emphasize. So it means that actually, in terms of the pharmacology, even 16 hours, not essential, 12 hours, because most of it's off board. Now, people will say, oh, see, it hangs around in fatty tissue. They never say, yeah, I don't care. That stuff's not actually in the brain anyway. It may be trickling out, but if I swamp it with enough buprenorphine, that's trivial. That's nonsense. Saying, oh, well, they're getting this auto dosing from their fat cells. No, that's tiny. If I give them 32 or 40 milligrams of buprenorphine, who cares? And if that's trickling out over days, said no, because the other great thing about buprenorphine is once we get enough on board, it's much more, it gloms onto those receptors. It actually has a stronger connection to the receptors in the brain than everything else, which is why it's so great. Even naloxone, whatever, won't knock it off. So it's like, once I got it there, so I don't care whether there's, leaking from, this theory of fat cells. And so, yeah, it's trivial. I don't care. Because you took more, you took enough the next day. We're still swamping it. So I don't even care whether you've got this little trickle of fentanyl that's coming out from 3 weeks ago. No problem. Right. So the most important thing, so I'm coming back around, I hope, you got to tell people, yeah, but you got to do it right. And one of the good things about having a prescription is we can get you enough so we can do it right. That's why, why work with a doctor? Say, well, no, why not just hand it out in the street? Said, well, right, because it's a little bit technical, and a lot of folks think that they know all about it, and they do know a whole lot. It's strange how much people know, but they don't always know enough to get started in the right way with Suboxone. And so that's something that you can tell them. Say, no, probably didn't do a good test. It is a great, great medicine when done correctly. And we can get you enough, you come in and work with us, we can get you enough so that we're guarantee that you will feel better. Okay. Sorry, Ashley, I know I haven't said, come back to you. You got your hand still up? haven't said anything about microdosing
Yeah.
yet.
I just had one more question just while we were
Sure.
on the topic of yeah, on macro induction. So one of the things that a lot of our participants are experiencing now is that fentanyl has been mostly replaced with xylazine, and the drug supply seems to have, you know, a lot less fentanyl than it does xylazine. And so kind of the new, I guess, worry that people have is that there are not enough protocols to cover xylazine withdrawal. And especially with the person that passed away in they were arrested out of Kensington, and this was in the news yesterday, and they passed away from what was supposedly like xylazine withdrawal in jail. May or may not be true, but
Right.
when those things go around now, we've got this worry of, are people, or are there protocols to help with xylazine withdrawal?
Well, so the easy answer is no. So xylazine is really tricky. There are some reversal agents for overdose, but people, you know, that won't be available unless people are in the emergency room. So that's why I said, you know, probably went right by folks, but when I said, look, you know, if people are saying they're using all of this fentanyl and the fentanyl's adulterated, and you've got a couple of people, Josh Swatek and Phil Feudy, know, you know, or really have their hand on the pulse nationally about what what's going on in adulteration. But so if people say, I use so many pills of fentanyl a day, and they take 32 or 40 milligrams of buprenorphine and they don't feel better, that's something else. That's either behavioral, that's adulterants, that's stimulants. That is the proof that it's not just the buprenorphine. And so the answer is, if they're really sick, they go to the hospital. So if they're still, you know, really out of it, and they got Narcan first, or they took all of that, because 32 milligrams of buprenorphine will absolutely, if people have a lot of fentanyl on board, and they think they do have fentanyl on board, will absolutely work like Narcan first. So if you didn't reverse it, they're nodding out, they're not alert, they go to the hospital, because that means that it's something else. It's not the fentanyl. And buprenorphine, they probably need it because they've been taking some fentanyl and they're all dependent. They're going to withdraw from it. But we got them enough buprenorphine. And then the other, you know, in my my constant plug for buprenorphine, such a great medication because it's perfectly safe. There is no problem with all the other things you're going to give it. I mean, I give someone in the hospital or to try to help them. And if they're not hospital sick, but they're saying, yeah, I'm pretty sure that I have xylazine. Said you're going to need a lot of other things, you know, a lot of mood stabilizers. There's lots of other things. Then that's my business. And you know, we've got to talk a lot about how we're going to help them through this. But if they're still really not right, and you've given them 32 or they've taken 32 or 40 milligrams of buprenorphine, they should probably go to the hospital. Okay, so that's where we are with that. Okay, and somebody else, let me try come eventually around to this low dose. Okay. No other specific questions before I get on to the low and micro dosing?
Can I ask a quick question
Of course.
and make a quick comment with the xylazine? I know we haven't seen too much of it lately,
Thanks.
but from what I read, like the problem with it is the withdrawal causes a like acute hypertensive emergency, right? So if somebody is mistakenly given naloxone for what is actually a xylazine emergency, is that going to react at all to anything they're given for the hypertension?
No, it's not a problem. But it's a good point Maria's making. Said, yeah, if they're not well and you're in the office and you've got any medical expertise, or in a health office, or you're in a place where you've got folks who know what they're doing, do vital signs, absolutely. Temperature, blood pressure, absolutely. Those are out of whack. They go to the hospital, because those are medical emergencies, right? You know, we do have. That's a good point, right? So they're all the agents, things like clonidine, absolutely then appropriate, but because we do not have a specific agent for it, they need to be seen in a place to say, okay, well, we're going to, monitor what's going on and get them through this by treating symptomatically. If it's a hypertensive emergency, then they've got to be in the hospital. If they're,
Because I think
they're
that's what we're going to see with xylazine, is that it's that maybe even with this anecdote that we heard, that it's likely uh, acute hypertension that may be why the individual passed away, probably didn't get vitals when they went to the hospital.
right, right.
And then with just really quick with the macro dosing, I know you were saying that, high doses, people feel really good kind of really quickly. And some of the feedback that we've been getting and pushback in maybe not wanting to start a program is that people don't want to be sick. So do you recommend adding comfort meds to that initial induction?
Sure. I mean, so for anybody who knows, since they all know what it's like to be sick, I mean, it really, so it's, I know from having worked together at Sunshine Recovery, said, yeah, when people in detox, people want a lot. These are the people who, barely can keep it together and will run out. So really just, as you're saying, we were working with the prescriber, with me, said, please give this person some comfort meds. So a lot of us say it's, the thing to remember about opiate withdrawal, everybody thinks if they feel like they're going to die, but nobody's going to die. So we're really talking about saying, look, it's effectively medical handholding. Say, look, it's not like alcohol withdrawal or xylazine overdose, which are medical emergencies, or can be medical emergencies. People, it's apparently the worst thing that anybody ever goes through, but it will not kill you. It will not. It's people will experience massive dysphoria, but it will not. I mean, it's unpleasant, diarrhea, and goose flesh and all that stuff, but that doesn't kill you. Okay. So, but if it keeps people in the game, any of those things are fine. So a lot of folks who, the more they know, the more they'll know that actually the thing that will really make them feel better is the buprenorphine. If they have good information and experience, that's fine. But all that other stuff is great. Sort of the standard thing was to give people. I don't where people seem well informed and have are put together enough that they can just follow the program. But if someone is really anxious, then of course we do that. And of course we know one of the other important subjects at some point is to talk about all the secondary sort of behavioral issues like anxiety disorder and depression and things that go along. Said, well, even if someone didn't have it before, all the stuff that you go through to maintain habits and what's happened to folks' lives. So of course they have those things. So yes, if we can address them, by all means, that will help. So no problem at all. And I think that the non-medical staff, when you're dealing with someone like me, said, please, by all means, say, yeah, I think this person really needs some stuff to help them to get through. Absolutely, no problem, right? Absolutely. Yeah. You could say, except for waste of medication, there's no reason not to give everybody that stuff. So you could say, well, the standard kit should be. So it's really just a judgment call. And if people, if you would say, look, please don't, with please give these folks something. Say, absolutely, no problem. Got many things we can throw in there. Okay, but very good points. Now, let me, before we lose this entirely, let me say something about microdoses. So along this theme, so the microdosing approaches came about because there are some people who are so terrified of withdrawal that they just can't stand the idea of being absent for anything. So what you do is you say, well, you give them a little bit at a time so they don't get massively sick. Now, my problem with this is, in this scenario, and why, I mean, even though many people, people who I absolutely respect are great proponents of this, but I'll tell you my reservation. It said, well, people who can't stand this and are having trouble and are using fentanyl, I don't know, 5, 6, 10 times a day. It said, when you make them a little bit sick, okay, and then you're going to take a little more. Say, what's going to happen? It took them 12 hours to do. It said, you say, no, at some point they're going to decide to go the other way, right? I mean, it said, because you're not making them feel better, they're feeling gradually worse. And so then the decision, so rather than making them feel better, saying, yeah, people who don't tolerate, who have very low thresholds for being too frustrated to get through, said, I don't understand the logic. Now, where does it make sense to me logically is in this last one here. Sorry, I'm pointing with my finger, that doesn't work. Microdose with cross tape. Well, that makes sense if you're saying, okay, and the other thing about microdosing is, in my view, and the people that I know, like Dr. Eric Ketchum, who really are proponents of this, say, it works under very highly controlled situations where you say, well, he's got them in the hospital and giving them all kinds of other things and setting things to get them through that. Said, okay, yeah, maybe it works then. Or the only other one that makes sense to me at all is this cross taper saying, okay, go ahead and use. You can use, but you got to be decreasing your dose as we're going up the other way. Because then you can say, well, okay, they're not constantly adding to it. But again, you still have this point at which the two are crossing. You're going up on the Suboxone and down on whatever, on the opiate, the presumably fentanyl. At some point, they're going to have this moment of saying, don't really feel good, don't have enough Suboxone to feel better. What am I going to do? It seems, it takes, as I say, it actually extends in my mind, extends the period of, mild withdrawal and dysphoria. And in fact, it's the big problem, which is a separate topic unto itself, is people trying to get off of methadone. Because methadone has a half-life of 5 to 10 days to get it out of your system. So people who quit methadone said, it's like withdrawing for a week. And very few people are tough enough just to do that, because you said, I'm okay, I tough it out for 3 days, and then it's like, I just can't stand it. And you said, yeah, if I give you Suboxone now, you're going to go into withdrawal. And so getting the dose low enough, or waiting for them to have little enough methadone in their system, so I said, yeah, okay, we both understand one another. I'm going to make you withdraw now, but we're going to get enough to make you feel better. Getting to that point is very difficult. So this is why I say, yeah, okay, you can make these microdosing regimens work under highly controlled situations, which is, have all the time in the world, talk a little bit about the behavior. Say, yeah, lots of things work under highly controlled situations, but don't work under, in the wild. And this is why, despite, as I say, people whose work I respect and lots of theoretical trials, BU studies and all of that, said, yeah, but the one that works for me is the one that makes people feel better quick. And all of these people know what it's like to withdraw. They couldn't get it together. They didn't get good stuff. They didn't have the money. They just got out from detention, whatever. They all know what, as awful as it is, they all know what it's like to withdraw. So they say, yeah, just, you won't feel good, but I'm only asking for 12 to 16 hours. That's not impossible. So that's where I sit with that. Now, if somebody says, no, the only way I'll do it is this, so by all means, so Ashley, so if they say, look, the only way I can't stand this, so fine, so we can put together, a microdosing protocol to help them out. The other thing is, one of the other messages in the stuff that, slides I'm not talking about right now, but maybe you'll either look at or we'll look at if we have time. Say, the other thing is, these things are highly individual. The experience, and as I say, there's a point about talking about people and say, well, what each person goes through with these things and trying to change behavior, it turns out stuff that will work for one person won't work for another. That's that's the message from all the behavior change, weight loss, learning things, all of these things. So yeah, it's really hard. And saying, if there were one magic bullet, everybody would use it and we'd be done. But it doesn't work that way. That's just the individual experience, both of the condition of the dependence and experience of, for purposes of opiate use disorder, the experience of the medical transfer over to a great medication is highly individual. So be aware of that, and just, both as all of your relationships with these folks, And then also, insofar as you interact with the medical staff, said, please let's try to take into account what they're telling us about how they can do this. But also, Monica's point before, saying, yeah, but if they've got all kinds of misinformation, we've got to clear that up. And I've had just dragged out battles with some folks who were sure that they knew exactly what they were talking about. Never done it the way that we understand the thing to work. So, okay, now other questions, or what was I supposed to come back to? I've already forgotten.
I think Ray had a question about
Right.
Yeah.
Ray, can you restate your question? Right. It was about how to talk people at the beginning.
I have it now. Sorry. I was just interested in the conversation. I think one of your slides covers some of it about talking to people who are not, they may be contemplating it, but they're not really sure. And, kind of a way to explain or describe that might encourage them to give it a try. Because we have a lot of clients coming in to exchange, syringes, and
Right.
we have a signpost that says, ask us about Suboxone, and they do.
Yes.
But I think it's more than that, and a way to meaningfully engage people in some kind of discussion that leads to the decision that's best for them.
Yeah. Well, so one of the things that, the first thing I think, in coming back to Monica's point, said, yeah, the first thing you can do is try to say, well, what do you know about Suboxone, and what's your information? Do you have any experience with it? Because in getting them, in particularly thinking about MOUD, say, well, we're in the business now of trying to get folks onto MOUD. There's not enough of it. So say there is a lot of misinformation. It's like, oh, if you only tried, half a strip on the street, that's not a good trial. So if it didn't, you said, no, Suboxone didn't work for me. I said, well, how did you try it? What were you doing? How long did you use it? What was your dose? How much were you taking at the time? And try, I hope I can provide enough technical information that folks will be comfortable saying, look, you got to convince us it is a great medication. And I have to say, this is someone who's worked as a family physician and worked in lots of different kinds of medicine, say it is a fantastic medication. It's right up there with the best things that we've got for the particular problem. So telling people, say, no, people, when you get on this, it's a great, great medication. So if you haven't tried it correctly, give that a try. Now, and say, no, I think I have. It's like, say, well, then I would say, I try to be, my view about this is to be really concrete. And you said, okay, well, you didn't feel ready, or it didn't work. Say, what stopped you, or what got in the way? Okay, try to address really concrete concerns, because why? Because behavior change is hard, and trying to give people a concrete step is important for everybody. But also, these are people whose lives have been governed by very immediate considerations for a long time. That is, I'm not telling anybody in this group news, but it's like, how am I going to be doing for the next 2 hours, right? What's happening to me in 4 hours? Do I have it? Can I get it together? At the end of the day, whereas how are things going to, are extremely, are governed, some, and this is part of the tragedy, is that their minds and lives are taken over by, very concrete short-term thinking. That's the nature of the disease. So trying to say, no, okay, didn't work before. Let's figure out one thing that we can get out of the way. And sometimes, these things are really straightforward. It's like transportation, it's like logistics, getting to the pharmacy, how do I deal with my family? People think that it's another addiction, whatever this kind of thing. Great, okay, let's focus on that. And again, something that I think is common to the world of behavior change is the feeling of both frustration and defeat. Because you say, well, you said we're going to do this and didn't fix it. I said, no, we got to give people some, little victories, right? I think that's really important in the whole, both for the human, and also in the notion of the feedback reward system that we're talking about in all habits, and say, no, you got to give them, we all need a little prize, right? It's Alice in Wonderland. Everybody gets a, prize at the race, right? Say, well, yeah, let's do something that we can show that we can, we can say, look, we got there, how long did, can you space out your use? Say, well, let's try, any of these things. And see, here's some suggestions. These are only suggestions, and I know a lot of them, everybody will have, better ones, but that I think is really important. So try to focus on something that something that would be doable for the individual. If you can help them identify those things, and what could we do to help you, or what could you do for yourself that might make taking the next step more possible. And that's I think, well, so far as I say, again, so there are lots of people out there who have a lot more to offer than I do on this, but that I think is how I would try to structure that. Does that help, Ray?
Yeah, I think one thing to consider too is buprenorphine is so successful in blocking the highs, and and the affinity and dissociation is so good that it really interferes with getting high. So a lot of people don't like to take it consistently in the correct doses so they can continue to get high. Because if you're taking buprenorphine, the chances of hitting those receptors are not really great with other drugs.
Excellent point. So if someone has to want to and said, well, okay, so you're not ready. And that's one of the other things to say to people. Say, well, you're not ready. What would, and then the question is, well, okay, in the state, say, well, what would you get ready? Well, there are people out there, and this is a discussion I've had with Dr. Novak, and say, well, there's a huge body of people out there who are not yet ready. And so ready is to say, well, okay, some of this is just exhaustion, but someone's saying, look, how long do you want this to go on for your life? Compromise. And I said, that's your choice. Nobody, and maybe that's okay. You're not, but then you'd say, well, look, okay, but what are the things that we can talk about? Say, well, look at what it's doing, because you're going to have the same high tomorrow if you get it together. But what else is happening? When was the last time you talked to your kids or grandkids or partner that you're trying to get back with? Or when was the last time you had a job that you felt like you were doing something that you you liked and gave you money that you put to other things in your life? So, so those are the kinds of things you say, well, try to get out, or you felt, didn't wake up and feel slightly bad about what you were doing, because everybody, there are very few people who say, no, I'm the perfectly contented addict, and, this is, leave me alone. This is what I want, from my life. I mean, there are a few out there. Mostly they don't last too long.
Yeah.
So, yeah, Monica, did you have something else?
Yes, I do. So I think this is a great presentation, and I've been waiting to hear about this from you, Dr. Leiderman. Fortunately, I have a background of all this counseling and what it entails, and I've been a substance abuse counselor, and I know a little bit about Suboxone and methadone, but our people that are dealing with this, like our clerks, they're getting calls, and they're not even trained or ready. Like, I don't feel like they're ready to have these conversations. I really would implore the state to bring on peer support workers to help with these transitions, because as you know, it's not just stopping the drug that makes it easy. It has all encompassing, right? Transportation, work. If I'm a prostitute on the street, I'd be less inclined to go have sex for food or a place to stay unless I'm high, so there's a lot of things that need to be addressed. And sometimes, we're opening up a can of worms, and some people aren't able to put that back. And I'd hate to turn somebody away. I just feel like if we had more peer support, even if it was, because you're like the only contact for the whole state that's interviewing these people that knows all about this, basically, for all our nurses. So Those are
Right.
my concerns.
Well, I think that I absolutely agree with you. I think the more different kinds of support that we can get and the expertise of everybody is really important. I will say, and having started out working, the way I came into this was working, knowing very little myself practically and working with staff that wasn't highly trained. I said, yeah, but here's what I would say. I mean, what you can do is provide instruction to some of the support staff and people with that kind of expertise, but not everybody has to do everything. So if the clerks would say, look, it's just a well-known said, look, I don't know everything that we need to know, but come on in and talk. We can put you in touch with somebody, right? Come on in and let's make sure your insurance is good, and your uh, support and for various social benefits has lapsed. Let's see whether we can work on that. And let me get you fixed up with the people who know some of these things about it. I don't know everything that we need to know, but we have people who know a lot about the medical side and about getting into programs and all this stuff. So just come on in. And in fact, I will say that, I just say, in all humility, there are many times when the thing that kept people, one of the things I say is, well, keep them in the game. We can't help people that we don't have contact with or who take off. So, but in a lot of my experience, it's the people who had very little training who just said, look, come on in. And sometimes they get mad at me, said wrong dose, doctor, you're gonna write medicines, I'm just pissed at you because you're the man, whatever. And said, actually, it was the people with very little training who kept them in the game. Said, okay, yeah, he's an annoying guy, come back next week and we'll get it fixed up, and and so that's where I want to say that even people with they can't know nothing, of course, then with your help, they'll know enough to have more information. But and unfortunately, a lot of people in New Mexico, even without training, know a lot secondhand. There's so many people with family members and so forth. So there's a lot. So that is something else I want to say. Yeah, we need all kinds of expertise, and we may not have it in every office. So we need to. One of the things I'm trying desperately to do, is with respect to the health offices, is how to apportion all of this expertise around. I can't be, but saying, oh, great, again, only gift of COVID was now we're doing this. You can say in a state that has a big geography with small population, really like New Mexico, and not enough professionals and licenses of any kind, said, how do we get it around? Well, gosh, look what we did. No reason. Now it's just a logistical problem. And that's why I say I want to hear, and so great. Let's have some sessions for the folks without licenses. So let's do that. Let's talk about stuff that's terrifying or where I feel like I'm out of my depth, whatever. So great. Let's do that. And I think that they can make a huge contribution, because I have seen it where I said, look, a person is furious at me and are in danger of just taking off. It was the other folks, people who come with very modest training who kept those guys in the game. So that's what I'm saying. But obviously we want to make years of training that folks like you have. So it's me. I could keep going. um, so let me just quickly show you so that when is that a good idea, Andrew? I'll just sort of blitz through the slides here. So you might know what. Yeah. Okay. So this is a list of things that kind of saying, well, okay, if I have my things that I wrote up to things I learned, it would be on there. Many people, I'm sure, in this group have many more and better. But things are another discussion. We did go through that. That's good. Links. I put in a note here, said often in these talks, you say, oh, this is all just, that's all window dressing. Somebody looked at that and, that's a reference, whatever. These are great. There's some great material out there. If you're not familiar with it, the addiction psychiatry boards have some great resources. The PCSS on there. There's one that's specifically about behavior, guidelines in there, motivation. There's one that's from SAMHSA, which is also really good. They tend to be longish, but they're really good. And even if you don't feel, it's not all technical, particularly when you're talking about the behavior stuff. Some nice things about the behavior change there. And then I got a bunch of other stuff on here, which is maybe useful when you're talking to other people, but it's, I think, including some stuff about xylazine and so on. You can just flip through this. This is, from other things I put together, but maybe useful, for people to review or talking, if you just want to sort of go through or look at it and then get back to me privately, text, email, phone, whatever you like, with questions on any of this stuff. So.
Wonderful resources. Thank you so much, Josh, for giving us all that great information. And I know if anyone's frustrated about the depth of it, we don't expect you to become an automatic drug counselor at this point, but we just want you to know enough to be able to talk to our clients when they are interested. And I think this did a lot of good, and we really appreciate you coming on, Josh. Thank you so much.
Anytime. Yeah. Thanks so much, everybody.
And since it's 11 o'clock, we're not going to be able to go over the liquid files today. However, I'm available and Tracy and Polly as well. If you have any problems with it, just give us a call. We'll get on Teams with you directly, and we'll just troubleshoot and look at the screens together and make sure it works. So thank you all for that great session, and we'll see you next month.